Welcome everyone to this explainer. Today, we're tackling an absolutely critical, high-yield topic for your pharmacology exams, congestive cardiac failure. To really ace those long answer questions and vivas, you need a rock-solid understanding of not just what these drugs do, but exactly why we use them. So let's jump right in. Before we start memorizing drug classes, we've got to answer this fundamental clinical question to understand exactly what we're trying to fix. Why does a patient with a failing heart show up with swollen ankles and literally unable to catch their breath? And honestly, more importantly, how do we intervene to actually extend their life instead of just slapping a temporary bandage on their symptoms? Okay, here is our syllabus for today's explainer: pathophysiology of heart failure, goals of therapy, drugs that improve survival, symptomatic therapies, and finally, exam pearls. Let's kick things off with Section 1, the pathophysiology of heart failure. Now pay really close attention here. Congestive cardiac failure is essentially a devastating mismatch. The cardiac output is simply inadequate to meet the metabolic demands of the body. At first, this might only happen during exercise, but as the disease gets worse, it happens even at rest. Because the heart isn't pumping effectively, we get a compensatory increase in fluid volume and central venous pressure. And that increased venous pressure, that's exactly what forces fluid out into the peripheral tissues, giving us pedal edema, and into the lungs, which causes that severe breathlessness. And this beautifully, or rather tragically, illustrates the trap the body falls into. This step-by-step vicious cycle is literally the foundation of your exam answers. The heart's output drops. In response, the body kind of panics. It thinks it's bleeding out, so it fires up the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAS. This causes massive sodium and water retention, and it clamps down on the blood vessels. So what does that do? It drastically increases both the preload and the afterload, meaning this poor, weak heart now has to pump way more fluid against a much higher resistance. These so-called compensatory mechanisms, they just end up choking the heart even further. Moving right along to Section 2, our goals of therapy. Right, so now that we see the trap, how do we get the patient out of it? Our primary goals aren't just to make the patient feel a little bit better today. To truly treat heart failure, we absolutely must interrupt those counter-regulatory neurohormonal mechanisms. We want to increase natriuresis to flush out that fluid. We need to completely inhibit the RAS pathway, and we've got to block that harmful sympathetic overactivity. By doing all this, we significantly reduce the workload on the heart, lowering both the preload and afterload. Ultimately, hitting these physiological goals is how we actually prolong a patient's survival. Which brings us to the core of your exam in Section 3, drugs that improve survival. Okay, this table right here is your absolute cheat sheet. Seriously, memorize it. If you only take away one single thing for your exam today, let it be the strict distinction between drugs that actually prolong life, like ACE inhibitors, ARBs, RNIs, beta blockers, and aldosterone antagonists, and the ones that merely reduce symptoms, like loop diuretics and digoxin. Never, ever confuse the two in your vivas. Let's start with ACE inhibitors, like ramipril or captopril. These are the absolute cornerstone of therapy. By blocking the angiotensin-converting enzyme, they stop the formation of angiotensin II. Now, angiotensin II is a super potent vasoconstrictor that also triggers aldosterone release. So by knocking it out, ACE inhibitors brilliantly reduce both the venous return, that's your preload, and the vascular resistance the heart is struggling to pump against, your afterload. Now, here's a fascinating little piece of medical trivia to wake you up, straight from your textbooks. Our most vital heart failure drug class was actually born from the venom of a deadly South American pit viper. Researchers found a peptide in the snake's venom that potentiated bradykinin, and that discovery ultimately led to our modern ACE inhibitors. Honestly, medicine is just incredible sometimes. But as miraculous as ACE inhibitors are, you absolutely must know their classic adverse effects for your vivas. Because they inhibit the breakdown of bradykinin, that bradykinin builds up in the lungs, causing this persistent, really annoying dry cough in a lot of patients. You also need to watch out for first-dose hypotension, dangerous hyperkalemia, and please remember, they are strictly teratogenic, meaning they are absolutely contraindicated in pregnancy. Let's look at a massive recent advance, the ARNI class. This combo of sacubitril and valsartan has completely revolutionized heart failure care. See, while standard ACE inhibitors or ARBs only block the bad RAS pathway, an ARNI does two things at once. The valsartan blocks the harmful angiotensin II receptors, while the sacubitril inhibits an enzyme called neprilysin. Normally, neprilysin goes around destroying our body's good, protective natriuretic peptides.
By inhibiting it, we boost those beneficial peptides, which significantly improves survival compared to just using ACE inhibitors alone. It's a real game changer.
Next up, beta blockers, specifically metoprolol, bisoprolol, and carvedilol. Now, historically, doctors were pretty terrified of giving beta blockers to heart failure patients because they reduce contractility. But we now know that chronic sympathetic overactivity is highly toxic to a failing heart. So here's the crucial example. If you start low and go slow in clinically stable patients, beta blockers protect the heart from that toxic adrenaline overdrive, they reduce cardiac work, and they definitively improve survival. To round out our survival drugs, we have the aldosterone antagonists, spironolactone and eplerenone. You see, even when a patient is on an ACE inhibitor, over time, the body sneaks around and finds alternative ways to produce aldosterone. We call this aldosterone escape. Spironolactone beautifully plugs this loophole. It stops aldosterone from causing sodium retention and myocardial fibrosis, which further improves mortality. Just be highly vigilant about monitoring your patient's potassium levels to prevent hyperkalemia.
All right, shifting gears to Section 4, symptomatic therapies.
The most famous of these are the loop diuretics, like furosemide. Furosemide will rapidly pull fluid right out of a patient's waterlogged lungs so they can finally breathe again, and it'll dramatically shrink their swollen ankles by forcing massive salt and water excretion through the kidneys. It makes the patient feel vastly better almost immediately. But, and you must remember this for your exams, it does not prolong their overall survival.
Then we've got digoxin, a positive inotrope. Digoxin works by inhibiting the sodium-potassium pump, which eventually raises intracellular calcium, giving the heartbeat a stronger squeeze. At the exact same time, it slows the heart rate down. This makes it a really elegant choice for a failing heart that's also battling rapid atrial fibrillation. But again, in patients who just have a normal sinus rhythm, it might keep them out of the hospital, but it doesn't reduce overall mortality.
But what happens if your patient crashes into acute decompensated heart failure or cardiogenic shock? Well, tissue perfusion is critically low, and oral drugs just aren't going to cut it. We need a rapid short-term fix. Here, we reach for IV dobutamine. It's a selective beta-1 adrenoceptor agonist, and we use it to forcefully kickstart the heart's contractility and bump up that cardiac output just to keep the patient alive in the acute setting. Let's wrap this up with Section 5, exam pearls. Seriously, take a mental screenshot of this summary table right now. Accurately mapping a drug class to its underlying mechanism and its specific clinical benefit is exactly what your examiners are hunting for. Knowing for sure that ACE inhibitors and ARNIs provide cornerstone survival benefits, while loop diuretics are strictly there for rapid volume relief, that is what will secure you those top marks. When you're sitting right in front of your examiner and they throw these classic Viva questions at you, deliver your answers with total confidence. Always point straight back to the pathophysiology we discussed at the start. Why are ACE inhibitors preferred? Because they reduce both preload and afterload. Why beta blockers? To stop that toxic sympathetic drive. Link the drug directly back to the vicious cycle it breaks. And please do not forget this crucial demographic pearl that comes up in MCQs all the time. The specific combination of hydralazine, which reduces afterload, and isosorbimononutrate, which reduces preload. This exact combo has been clinically proven to prolong life specifically in African American patients with heart failure. It's a really vital piece of targeted pharmacotherapy to keep in your mental toolkit. I'm going to leave you with this final provocative thought today. To truly treat heart failure, you aren't just trying to squeeze more force out of a weak, dying muscle. You are strategically silencing the loud, destructive neurohormonal alarms, the RAAS and the sympathetic nervous system that are actively destroying it. Master the neurohormones, and you absolutely master heart failure. Good luck on your exams, and I'll see you in the next explainer.